Well, I just want to thank you for the special honor of having me come to the state of Texas. Now, in full disclosure, I'm from Arkansas, so I don't always appreciate Texans beating us in football or basketball, but I'm not going to hold that personally against all of you. I know you're friendly folks, as they say. I'm going to talk today about sort of like the tale of two cities and talk about what's happened with Indianapolis in regard to maternal and infant mortality. And at the end, I'll make some, give you some perspectives or ideas of the initiatives that we've implemented in Indianapolis. But I will say that you guys honestly are doing an incredible job. When you look at the work that you've done and how you've engaged different community partners, so I just want to commend you at the beginning for the incredible. I looked at your numbers and I'm saying, my goodness, did y'all really want me to come? I mean, based on how well you guys are going in the right direction. So you have so many things that are already in place. I just have to commend you related to that. Let's see. So just to give you a little bit idea about what Marion County is, our MSA area is about 1.8 million individuals. We have 970,464 residents. I think Fort Worth, your population is about 780,000 compared to Indianapolis at 970,000 residents. If you look at our racial makeup, we're at about 62% white. Our African American ratio is a little bit higher than yours considerably. We're nearly 30% of our population is African American, whereas here in Fort Worth, you're 18.5%. So we're nearly double what you are in terms of black patients. But when you look at your Hispanic population, we're at 10.5%, and you guys are at 27% of your population in Fort Worth are Hispanic or Latino. And our Asian population is about the same, about 4.2. We may have the largest Burmese population in the country. We're having folks, because we have such a large group in Indianapolis, they're coming from Massachusetts, they're coming from Minnesota, because they all want to be part of a culture where there's a large number of them reside. And then our Native American percentage is at 0.5%. Our Pacific Islanders at 0.1%. And Marion County poverty rate, we're at 18% if you round it off. And here in Fort Worth, you are doing better economically. You're at a 13.6 poverty rate compared to our 18% poverty rate. And let me just say how that's made a difference. We average, when you look at the homeless population, we average about 1,500 people a night in terms of homeless. But when the COVID epidemic occurred, we shot up almost over 1,000 added to that number. So we were looking at somewhere between 2,000 to 2,500 in terms of our homeless. And guess who were the majority of the homeless in terms of significance? So African Americans made up somewhere around about 54 to 55% of that homeless population, and we had a significant number of African American or black women who made up that homeless factor, and a lot of them with children. So when you're talking about if you may be pregnant, you're in a homeless shelter, that you're on a mattress that's maybe 2 feet from another person in those homeless shelters. And we were so overwhelmed with all of our shelters. We didn't have enough space for all of the residents. And so our health department, we went into the homeless business, hotel business at that, taking care of pregnant mothers as well as other women and gentlemen. And so because everything was, stay in shelter, we had so many percentage of our folks weren't able to even go to the hospital. Couldn't make any visits when we were staying shelter, closed up for a long time. And it took a while once we reopened for people to gradually come back. But since I'm being recorded, I can't say anything very negative about our transportation system. The mayor might get me, okay? But we have the kind of transportation system where everybody has to go downtown first and then take a bus to the area where they may need to be. So you may be 5 blocks from a grocery store, but I have to get on the bus, go all the way downtown, and then come back to that grocery store maybe 5 miles from where I reside. And if you're pregnant or if you got little kids you're carrying with you, and you got to think about it, how much can I carry? Even if I go to the grocery store in order to come back. And then, my goodness, it does snow, I hear, in Texas. But we really have more significant snow than you. So when you're talking about the winter months, it's just incredibly difficult when we look at that. And everyone knows the definition of infant mortality. So I'll move on with that to just highlight our infant mortality efforts. So this is 2020, and our overall infant mortality rate was 8.9. Fort Worth, you were closer to a little over 6.2 infant mortality rate. So your city is doing way much better. Now that was my last date I looked at was in 2018 or 2017, so I don't have your recent data. But we were impacted because of the COVID pandemic, where you will see we were going in the right direction, but the COVID pandemic really kind of had us going back up. But our Latino infant mortality rate is the lowest at 4.6%. And we'll come back to this, okay? And there are reasons why their infant mortality rate is so much lower compared to our Black infant mortality rate, which you can see is almost 3 times the rate for the Latino. But if you look at the white infant mortality rate, we're at 7.7 compared to the state of Indiana at 6.6 and the United States national average at 5.4. Blacks make up about maybe 8% of the entire state of Indiana. So there are 2 locations predominantly where you see African Americans are Black. That's in Indianapolis and Gary, Indiana, which over 95% of the population in Gary are Black or African Americans, which is located on the border right next to Chicago. So no surprise here. That very top line is the line that shows, look at the difference of the Black infant mortality rate compared to all of Marion County, which is that second line. And the Hispanic line, as you can see, really dropped in 2018, 2019, and then dropped 2020. So you can see that our Black had an infant mortality rate greater than those other deals. What's associated with? These list at least 10 zip code areas in Marion County where the infant mortality rate is at least 10 or higher. And look, 46202, the infant mortality rate is 23.7, unheard of. But it'd be no surprise to you that it might be associated a little bit with the poverty level in that particular zip codes. And you can see we've had 3 zip codes, 18, 18, 23 deaths in those zip code areas. And this just highlights in the very dark, the darkest blue, those are the same zip codes where we have our infant mortality. And we also know that this is the zip codes where we have our highest concentration of Black patients in those areas, as well as having the low poverty rate. So overall, when we look at our infant mortality rate, this may be of interest to you. We were at 11 in the year 2019 for the Black infant mortality rate. The Hispanic has stayed low, like at 3.5 in 2018 and 4.6 in 2020. But look at the age group. So if we're looking at infant mortality based on the age, so you will see that we had the highest infant mortality at 8.9 in the age group 25 to 34. And our 18 to 24 had a little bit higher infant mortality rate compared to if you were 35 or older at 5.2. And so that highlights that except for in 2019, this is what we primarily have seen in the past, historically always, that the woman who was 35 or older always had a higher infant mortality rate until this year at a much lower rate compared to those other two age groups. Now, our top 5 causes of infant death, number 1, prematurity, okay? Short gestation and low birth weights, what we see naturally. Number 2, congenital malformations, defects. And then 3, we have other symptoms related to abnormal clinical and laboratory findings. Because the numbers are so low, I'm primarily just talking to you about number 1 and number 2. If we looked at it broken down by race, prematurity and congenital defects if you were a white infant death. If we looked at blacks, prematurity was the number 1 cause of death, and preterm. And if we looked at the Latino infant, primarily congenital malformations, birth defects was the number 1 cause if you were a Latino mother. So what does that tell you? For the Latino mother, it is based on their nutrition and their vitamin deficiency. So when we look at folic acid deficiency, we see a much higher rate of that. And this is, people living for the lifetime of their life. They've been based on their nutrition. What have been their long-term experiences long-term is related to their ability to be on prenatal vitamins early, but also making sure they get folic acid. So one thing you always want to look at that we have found in our Latino patients. As for the African American or black women, we predominantly see both deficiencies. Iron deficiency, anemia, in a significant number of our black patients, plus the folic acid. So they have the combination of both. The iron deficiency anemia, which is a contributing factor to the prematurity, but also the folic acid deficiency. So the risk factors, of course, preterm birth, birth defects, low birth weight, maternal complications during pregnancy, and the unsafe sleeping practices. Now, that has been a very tough nut for us to crack. So having our mothers place their babies on their backs, or we see pictures all the time where the parents are sleeping with their baby on their chest. I just had another physician show me her husband fell asleep. He was a big guy too, with the baby on their chest. And she thought that was cute, and my concern was, wow, if he had turned over, that would be a very frightening situation, and does she not recognize this? And so So many, oh, my grandmother told me it was okay, we were fine. You know, none of her kids got hurt, so it's okay to place my baby on their stomach face down. And they don't seem to understand the significance of this, despite a lot of the education. You're having the education against someone, if within that home, telling them what they think is the appropriate way how to take care of their grandchild or their baby. So still a lot of work has to be done in that area. When we look at our low birth weight, of course, you know, for those babies has an increased risk for cardiovascular, respiratory disorders, more importantly, the delayed motor and social developments and learning disabilities, that no surprise that the black infant has almost double the rate of low birth weight compared to the Latino patient as well as the white patient. And so I think Dr. Brown talked a little bit about this. So, and I'll have a later slide that talks about why I think we're seeing a higher rate of prematurity and low birth weight compared to any other race with that particular ethnic population. And you can see it's considerably greater, between 12% to 16.5%, almost twice as much as their white and Hispanic counterparts. If we looked at it based on their age of the mother, we find that we have a much higher low birth weight if they're under the age of 18. So that's interesting, or if they're greater than the age of 35. We see the highest association with low birth weight. Let's see. So what's that risk factor? Smoking and alcohol consumption. And what happens when you smoke? You know, our young teenage mothers used to tell us, well, I'm smoking because I want to have a small baby to make sure it's not painful for me when we have our delivery. So if my babies, they told me I can have a small baby if I smoke. So literally, you have to do focus groups and talk to these folks to understand their concept or their rationale, and you're just amazed about this, the percentage related to this, and so how do you address that education? But so if someone had a previous preterm birth, they're at a higher risk for having that. It depends on sometimes contaminated water with lead, low educational levels or income we saw associated with a higher rate of low birth weight. The stress, domestic violence or abuse, which we saw, as Haywood mentioned, we've seen a significant increase of that in our communities, as well as being single. And preterm births or births that occur before 37 weeks of gestation associated with a lot of hearing, delayed vision, and breathing problems, unfortunately even death. And so again, you see, if we looked at it broken down by different racial and ethnic populations, your black patient has a considerable higher rate of preterm births compared to all the other different ethnic races. But you see now that the white and the Latino patient are about equal in terms of their preterm births. So let me just move here. So how good are we in getting our pregnant mothers in the first trimester? Because that's so important in order to meet that criteria of adequate prenatal care. You have to have at least 6 or more visits, and they have to commence in at least the first trimester. I mean, you got to put these folks on their prenatal vitamins. And so what good is the vitamins, and how long will you have an impact if they're making it in the second or third trimester? And so how are we designing our healthcare systems? You know, it's tough. when we're trying to get patients in for their prenatal visit, and when they recognize that they're pregnant, and then when they're ready to go to be seen, they may call and ask for an appointment, and it may take a month before they can get in. And so, you know, sometimes it's just like someone who may have a substance abuse issue, who may have an addiction. When they're ready to go, you have to figure out how to get them seen immediately. Otherwise, you may lose that ability to get them in a timely fashion. So I don't know how many of us, and how long does it normally take for an average person if they call, and this is a first-time visit, to be able to get in? Anyone? Anyone know what that's like in your system? Does anyone have, one of the things we realized in Indianapolis when we had all of our hospital systems getting together, that it could take as long as 30 days before someone could get in to be seen if they were pregnant. And so we initiated the process of, well, what if we could get the patients in within 2 weeks of their call for their appointment, but they're seen by a nurse practitioner, where they can be started on, or the appropriate physician assistant or whoever appropriate healthcare professional, where they can be started on their prenatal visits. They can get all their blood work, urine studies already done. So by the time they're now seeing their provider, he's already looking at, he has a history related to them. He already has the laboratory results. He knows they've already begun on that prenatal visit. So it really has made a difference for us in terms of health outcomes if you can set up that type of system to make sure that they are getting in early enough for any care to take place. And they're screened. We're seeing a syphilis outbreak in Marion County, something similar to what we've seen in Los Angeles. And so we're seeing congenital syphilis cases that need to be screened early in these cases in order for them to prevent any congenital birth defects related to these deliveries. And so really important. So when we look at our first trimester prenatal care, at 75%, our white patients are almost meeting the 2020 goal. We're just short by maybe 1.5% for our white patients. But then we drop dramatically to our black patients, where the first trimester prenatal care is at 53%. And then if you look at the Hispanic, that percentage drops to 40.50%. Now, I want you to pay attention to that, because the Latino patient has the lowest percentage getting into the prenatal care. But what did I show you? They didn't have that prematurity. They didn't have that high-low birth rate. So what are they doing? And even their infant mortality numbers look phenomenal, even better than their white patient counterparts, but yet they are the lowest in their prenatal care. Now, one of the things I will tell you that is an issue for both black and Latino patients is a lot of them don't always have a primary care provider. So they don't have one until they come into the system with their pregnancy. So their ability to know even where to go, I love to tell this story, Dr. Brown, when he was at St. Vincent Hospital, I just love this one. We had a whole migration of Latino patients coming into our city. And a lot of these, I got the call from one of my colleagues who's a Latino provider saying that, hey, we need these patients to be seen from a family practice or OBGYN provider. And I says, fine, so let me just say, where do they want to go? Well, they wanted to go to St. Vincent Hospital because it's a Catholic hospital, and they felt very comfortable from their culture and their faith to go to a faith-based deal. So I called my colleague here and I said, well, I'm telling them that they can refer their patients to you for OBGYN. Remember what he just said about, how he was the service person and you can send the patients to them? Well, we saw 2 buses roll up at St. Vincent. They had about anywhere from about 80 to 100 pregnant women getting off the bus, coming to the register to say we were here to get taken care of. And so he got called down this.
Just to share.
Yes. So these were 80, it was at least 80. Oh, yeah. And so he couldn't believe it. I won't tell you what he said to me on the telephone. But he was calling every family practitioner, every nurse person, every colleague he had, and they took care and saw all of those 80 pregnant women that day because what can I just say, it was just an incredible hospital, incredible doctors, and then they became known as the hospital of choice for all pregnant Latino women. But they finally shared the wealth with us. So, and again, you can see the bottom line is the Latino population with the lowest prenatal care, but with the white patient, which is the green line up at the top, are almost meeting the 2020 guidelines. And so if we look at it by age, how well do they do getting in the first trimester? It's no surprise if you're less than 18, they had the lowest percentage of getting in the first trimester based on the age of teenagers. So whether they didn't recognize or know that they were pregnant from missing that period, or they were concerned about it, or didn't know where to go, that's the greatest group that we have to reach in terms of trying to get them in early enough. And we know we need this pre-pregnancy care that needs to be taking place. Even if you think you're going to possibly conceive, how do we start educating folks from a nutritional standpoint to have their body prepared like they should? But then, no surprise, the next group had the lowest at 53% was the 18 to 24-year-olds. And then following, by the time you were 25 to 34, smart enough to know you needed to get in, and greater than 35. So that group, less than 18, 18 to 24, is the one we have our work cut out for us. Now, we have a problem with smoking in the state of Indiana. And we probably have one of the lowest cigarette tax rates in the country. So, and we sort of precipitate cardiovascular disease. If you even look like you're going to tell our policymakers they need to raise the cigarette taxes, it seems to trigger cardiac arrhythmias or complications, and we have not been able to resuscitate them enough in order to not require a brain transplant in order to help assist them with their decision making. But as a result of that, because of our smoking, which causes low birth weight and prematurity, you will see that our highest smoking rates are in our white patients at about 13.10%. Our blacks are smoking at 6.9%, and our Latino population has the lowest smoking rate at 1.90%. So you can see that because of that low smoking rate, one, it helps to impact SIDS, sudden infant death syndromes, which you don't see occur in a lot of their households and generations because their smoking rates are low, okay? And it also helps considerably that even our blacks have a lower smoking rate that helps on some level. Let's see here. But the age group for smoking, maternal smoking, is 3% under the age of 18, 7.5% between the ages of 18 to 24, and 8.5% 25 to 34. So that's the group who are smoking the greatest during their pregnancy. Now, breastfeeding, as you know, really reduces the risk for obesity. Also cuts down on ear and respiratory, you know, I'm a bug doctor, infectious diseases. So it really cuts down on the ear and respiratory infections. And this is critical, especially for, we have collaborated with the Indianapolis Chamber of Commerce with all the businesses in Marion County. Because when you look at what is one of the number one factors for why a lot of their employees from absenteeism from the job, guess what, is taking care of a sick child. What did I say now? One of the major reasons for especially female employees to be able to be absent from the job is taking care of a sick child. So if we could address acute respiratory and ear infections in that child, it would make a huge difference on their bottom line, but also be more productive. So one of our biggest initiatives that we have taken place this year, spearheaded by Dennis Murphy, who is president of Indiana University Healthcare System, and Gail, the CEO of Anthem, Blue Cross Blue Shield. I was the co-chair for the maternal and infant child part of the project, where we all agreed that we would really push breastfeeding in all of the businesses. So some of our community-based organizations, like the Minority Health Coalition of Marion County, has pushed breastfeeding in our public libraries, so that for their employees, you have a location, a lactation room where you can go. You have a refrigerator where you can store your milk. But even more important than that is it's the level of education to your managers and supervisors, that if you have a male supervisor, the sensitivity of how he deals with a female employee when she says she needs to go to the lactation room, and time should be made available for her to do that, and how much time she's going to have, if she's swollen, she's overweight, how much time, if you're working in a plant, is she standing up in terms of being taken care of. So a lot of training is being pushed by our businesses, and we're going to start giving a label to them in terms of, are they a friendly place to work, and do you get the gold star, platinum star? You don't even rank as a star based on the services that you offer. So we're very excited about this, and this process is going to be evaluated to see how successful we are. And the businesses appear to be very excited to relate it to that. So when we look at breastfeeding, sorry about this, less than the 8, I think I missed one. Okay, sorry, wait a minute, I'm going backwards, sorry. So when we look at breastfeeding, our Latino mother, 90%, you round off 89.70%, have exceeded the 2020 goal for breastfeeding of their children when released from the hospital. So you now see one of the major reasons why their infant mortality rate is low. They're getting those maternal antibodies that are taking place. And this is a generational, they have that generational support. Their support system is very, very strong in terms of taking care of them. So at 90%, 2020 goal is 82, they're at 90. When we look at our white patients, they're almost at the goal of breastfeeding because they're at 80%, and our black women are the lowest at 75%. Not quite there, but really working hard to get there. Let's see. So, of course, it's no surprise that the younger you are, less than 18, it's really tough for women to breastfeed, especially in adolescent. And those first 2 weeks after discharge is really critical. And if you can make it, they can make it through that first 2 weeks after discharge, then they're pretty good about the breastfeeding afterwards. But that's the toughest, yes.
Is this exclusive breastfeeding or any breastfeeding?
So this is, so explain your question again.
Is it this exclusive breastfeeding?
So no, this is exclusive breastfeeding. Okay, exclusive breastfeeding, yes. And yes, please,
Is it initiation of breastfeeding?
So what happens a lot, and I'll talk to you like about the black patient. So they initiate their breastfeeding right out of the hospital. But what happens for a lot of black patients is after about 2 weeks to a month, after they don't make it even quite a month, it's just such a chore, a barrier. They don't always have the support. They stop the breastfeeding, and that 76% can drop down to about 50-some% within 30 days because they just can't sustain it and whatever. And they take the easier route with the baby formula. But we know, preferably, we like to keep mom breastfeeding at least for 6 months. That gives us the most protective impact for that child if they can breastfeed for at least 6 months. Moving on. Adequate prenatal care, where she's making over 80% of her visits. She's got to start in first, second, third, or fourth month of pregnancy. And when we look at adequacy of prenatal care, we see that the white pregnant mom gets 76% of her adequacy of prenatal care. If you're black in Indianapolis, it's 56%, and if you're Hispanic, it's 50% in terms of adequacy of prenatal care. And if you look at, no surprise again, based on the age group, it's no surprise that the youngest age group has the lowest adequacy of prenatal care. They just don't get in like they should in that first trimester. And then that 18 to 24 is the next level of having a lower adequacy of prenatal care. And then our Medicaid recipients. We found that what percentage of our patients, pregnant mothers, are on Medicaid? Well, 58% of our pregnant mothers, black, are on Medicaid, rounded off to 60%. So 40% are not, but 60% are on Medicaid. And if you look at the Latino population, 78% of our pregnant moms are on Medicaid, 78% of the Latino. So a much higher rate of our pregnant women, the highest our Latino population, with our white pregnant mothers at 34%. Now, some of the issues we have with infant mortality and some of our providers, they will wait. You don't always, depending on what state you are. We had recently, we had our laws changed, but some used to wait until they got the Medicaid approved before they would see a patient. And that could be a delay of 6 to 12 weeks before that patient could come in to see you. So we just last year were able to get presumptive approval. So, if you were eligible, that you could come back. Once you got approved, you could go back if you saw the patient earlier and still get reimbursed. But that's not the case necessarily across the country, and it really impacted us greatly because we had a lot of providers say, I'm not taking Medicaid patients anymore. stopped seeing them and then didn't want them to start seeing them again. So very tough related to that. So our poverty just highlights, all those dark circles show 100% below the federal poverty line by census tract. And our highest poverty was related to our Latino patients at 34% compared to 27% for black patients and only 14% for our white patients, a greater poverty level for our people of color. And no surprise that when you looked at poverty by education status, that if you had less than a high school degree, 32% of our folks met the poverty guidelines, federal poverty guidelines. 17.8% if they were high school graduate met the poverty rate guidelines, but if they had some college or an associate degree, 13.8% were in that poverty rate spectrum, and if they had a bachelor's degree or higher, 5.3%. So it highlights, and I'm going to talk about this, how social determinants of health are really critical in making a difference with your patients. So that educational attainment. So why the health disparities with blacks and Latinos? The environmental stresses and toxins. And so, like he's trying to tell you, it's the chronic inflammation, it's the stress. And I don't care if you're black, you may have a higher graduate degree, you may be economically doing extremely well, you still seem to have similar rates of prematurity and preterm birth. Now, guys, you might say, do I look kind of nice today? Do I look like I'm a thief or a car robbery person? Indianapolis is known for the Indy 500 Motor Speedway, if you didn't know it. It's one of the biggest, largest sports events in the country. And so they, out of courtesy because of our hospital, Ashkenazi Health, I think we're the 4th or the 5th largest public health hospital in the country, they allowed us to use their studio system to do a taping that we wanted to do on behalf of we just built a new hospital. It's about 5 years old now, but just before the epidemic. So I was driving in this area we call Speedway, and I was driving, and guess what? And I was looking sharp. I had my hair fixed and everything, and makeup, because I knew it was going to be on television. So I got stopped by the local police officer. And so I'm in the car, and I'm saying, and I will admit, I sometimes have a heavy foot, but I had just left the stoplight, and I said, well, I could not have been speeding because I just left that stoplight, so I know it's not that. So he came up, and you just say, sir, can you tell me why I'm stopping? And he was not a very talkative guy, but on top of that, he didn't answer me and looked at me like, you shouldn't talk until I talk to you. And I said, he may be having a bad day, so I'm not going to say anything more. I'll just sit here quietly. And then he finally said, ma'am, you're going to have to step out of the car. And I said, oh, shoot, I hope nobody's watching me that knows me getting out of the car. So he made me get out of the car and everything. So I'm out of the car, and he finally says, ma'am, you are in a stolen car. And I says, oh, is that all it is? And I say, I can explain this if you allow me to just reach inside the window. On the dashboard, my car had been stolen at a church event like 2 nights before, and they finally tracked my car on the south side of town, and I had just picked up the car, and I was driving. And so, and I said, sir, I have the paperwork and can show you who was the person at the police station who handled this, and you'll see I've got a statement from the corporation that says that I am the owner of this vehicle, and it's certified and all of that. So then he gives me the riot act about I should have fixed the system and cleared this out of their police system, as though I have the ability to go into the police system in order to correct their system. And I just said, yes, sir, I will get right on it. Now, my question to you, though, is, to me, I felt he was sort of discourteous. He was not friendly, treated me like I was a criminal. And I thought that with my look, because I was looking clean, very professional, and hair, everything, I would have got a little bit proper respect. But I have to be honest with you, I wondered if I'd been a white male, dressed in a suit, might he have treated that person a little bit differently than me? So where I'm going with this is, because of that cortisol, fight or flight that's going up and whatever, and the stress related to this, my perception of stress might be a little bit different than, say, someone who's a white counterpart, maybe driving a BMW or a Lexus or whatever. And I just had a mere Ford Taurus, okay? It's just a mere Ford Taurus. And hey, I know how to buy cars from support our country. But I think that you can see sometimes what are the things that we go through. I may be in a 7-Eleven gas station, and I know that when I go in the back to get orange juice or a drink, you might think nothing about it if you're white, but I think that, wow, I'll have the store clerk kind of come behind, just trying to watch to see if I'm stealing anything or whatever. So this is an experience sometimes that we get based on the people of our color that we may be a little bit more sensitive to than our white counterparts. But over time, that chronic inflammation, those cytokines, the cortisol levels can impact your different muscles of your body, which can create to the preterm birth and prematurity. So the systemic biases, how well we are treated, or our perception of how well we are treated. And sometimes I think it's nothing personal, but I think it's a gender thing too, Mm-hmm. I think sometimes, I'm sorry to knock you males, I'm just going to knock you. Sometimes I wonder, are we tuned out sometimes when we're saying something, or we're talking to our resident? Medical students are better, but talking to our residents to say, I think I have an issue here, but they don't perceive it. And that, I think, to me, sometimes I look at Serena Williams, worth $400 million for her one baby pregnancy, and states, hey, I'm having some shortness of breath. They poo-pooed her. $400 million. Now she known, and she's having shortness of breath, and she says, no, I'm having shortness of breath. Now this is a young lady that's already had a deep vein thrombosis before, a blood clot in her lungs. She understands the significance of having a pulmonary embolus. And yet, finally, after insistence, the resident does a chest x-ray and tells her, see, it's normal. And so all of your discussion, I told you, I listened to your lungs, you were fine. And so we're finished here. So as soon as he left the room, she called her manager up and says, hey, get me out of this hospital. Because she was smart enough to know that a chest x-ray doesn't rule out a pulmonary embolus, only a CT scan does. And yet he tried to play her by saying, hey, I did a chest x-ray and now you're okay. So when the nurse came in and she says, what are you doing? I'm getting my stuff together, I'm leaving. Well, of course, now they called the CEO of the hospital. Any CEOs in here? Okay? All right? Call the CEO of the hospital to say, hey, one of your famous guests is getting ready to leave. And she says, hey, you don't seem to respect when I say I've got a problem here. You're not taking me seriously. And I'm not going to die from a pulmonary embolus, a blood clot to my lungs, because you're not taking me seriously. Hey, they had the chief of OBGYN in her room within an hour. They had that CT scan scheduled. Of course, it showed a pulmonary embolus. But what do you do when you're not Serena? You don't have $400 million to your name, and you know that something is wrong, but you can't get that person to do the proper, appropriate studies that you can. So we have a younger generation. I think our older folks, we're better at this because we're used to doing more diagnostic stuff, and listening to the patient, and we depend upon a lot of the equipment. But I think this younger generation, it's more difficult for them to kind of understand this, and they make assumptions that they shouldn't always make. So this is what you have to think about, that these patients are thinking about when you are taking care of them. Are you taking me seriously? Do you value what I say? And it makes a huge difference in that communication front and back, which in terms of someone being compliant. And my last statement I just want to make related to this. I had a young lady, had a 2-week baby. She was in the hospital because she had sepsis. And she needed to be treated 10 days with IV antibiotics. And she says, I can't stay here 10 days. And I said, well, you need to stay here or you're going to die. I can definitely promise you that. Well, I've got to have somebody take care of my 2-week-old baby. And my girlfriend can do it, but she's about to go on vacation. And if I asked her to do this over the phone, she's going to tell me no. My other 2 kids can be taking care of my father's mother, but she's not going to take care of my 2-week-old baby who's from another father. So she says, I've got to sign out. So they made her sign out. But if you read her notes, it says she was a non-compliant patient. And what she said was, I will be back in 24 hours. But if you read those medical records, your interpretation is they never explained anything about that she was going home trying to explain her situation so someone could take care of her 2-week baby. And her girlfriend decided to delay her vacation, took care of her 2-week baby. She was back there in 24 hours, but the chart had labeled her as a non-compliant patient. And so if you had seen her at some future visit, you say, oh, I got a non-compliant patient here, when that was not the case at all. So we don't always accurately report in our documentation about the situation, so we're not misinterpreting our patients. So access to quality health care, that is critical. Poverty, we have to address it because of the disparities, and social determinants of health. What this COVID pandemic clearly told us, that unless we address the social determinants of health, we're going to continue to have poor health outcomes. So who's concerned about a prenatal visit when I don't know if I'm in an apartment, whether my electricity is going to be on, or how am I going to feed my kids on the table? Why am I worried about a prenatal visit? I got more pressing issues. And so unless we can address those pressing issues, why should we expect better compliance? So we got to know that the system is not just in your patient room, but what as a community are you doing to address stable housing, food insecurity, transportation issues? Hey, we had a contract with Yellow Cab. They'd be picking the patient up 1 hour after their prenatal visit to carry them to the hospital, still expect to be paid. And no fault of the patient, but the system that we set up with this cab company. because their reimbursement was not as high as a regular customer, they always got the second end of the stick. And then you could only call one day of the week for your appointment, way in advance, and you're competing with no one ever answering the phone or the signal being busy. So, excuse me about my food desserts, but it should have said food desert, okay? I was tired. I got in like at 1 in the morning, okay? But how do we prevent maternal mortality? We've got to manage the hypertension in our patients, but they've got to be there to manage them. And we got to learn how to teach our patients, okay? So, hey, how many of you offer a blood pressure cup to your patients to take blood pressures in their own setting? How many does that? Hey, and listen, there's systems now that electronically, you don't even have to depend on your patient. They just got to put that cup on. Electronically, you'll get that reading electronically. But I think that's the new direction we've got to go. We've got to know that if you're at risk for postpartum hemorrhage, and who's at risk for postpartum hemorrhage? Those mothers who are anemic. You're at a higher risk for postpartum bleeding. If your hematocrit is less than 30, your hemoglobin is less than 10, they should be taught what those signs are to let them know when this may be serious. And that's the indication for an aspirin. Who should be getting an aspirin during their pregnancy? History of diabetes, chronic obesity, you've had chronic hypertension, you're over the age of 40, you've had a prior pregnancy loss or prematurity. Are your patients on aspirin related to preventing maternal mortality? And of course, if you're like Serena, are we screening for lung and lower extremity blood clots if they've got swollen feet, okay? Swollen lower extremities. And how to prevent infant mortality? No smoking, safe sleep, breastfeeding, appropriate newborn screenings. Prevent our birth defects, but follow up, follow up, follow up. Post-discharge. How many are you seeing them 3 to 7 days after their discharge? You got to come back. 3 to 7 days after you discharge, are you seeing them 3 to 7 days? And then you still got to see them again. But what does our follow-up look like? That's critical. Are they, able to do what they should be doing? Breastfeeding? Need any help? How would you know if you're not making sure you've got a system that's designed to follow them up? And so what can we do? Listen, listen, listen to your patients, okay? Listen to them to find out what's wrong. I know the services that we offered at our health department. We went to a HUD authority, low-income housing folks, to talk to them about our programs, our WIC, Women, Infant, and Children, and our other prenatal programs. And wow, Dr. Cain, you guys do a lousy job. I said, ooh. Are you sure you're talking about the right? Yeah, we know what health department we're talking about. And your hours are based on what's best for your staff, but not what's best for us, okay? And you don't have no evening hours. You shut your clinics off at 5 o'clock Friday noon, and you're going to have to do better. The other thing we realized was that some of the materials that we provide in resources, it was kind of the materials that looked like for poor folks, honestly. It just was not of the appropriate quality, high staff that you like to see. And we need to partner with our hospital systems, and they won't want to partner with us if my materials resources look like they're piss poor. But we have to also think about incentives for a lot of these pregnant mothers. What can we offer as incentives? I'll tell you about one great program and I'll stop. And I have no shame whatsoever. But we had a program from one of our smaller counties in Indiana that talked about a program called the BAGE program. This is a program where they provide cribs, car seats, prenatal clothing items, Pampers, you name it. They provided it free based on getting coupons. You get so many coupons if you keep your prenatal visits. You get twice the coupons if you bring in the father of your child to your prenatal visit. You get coupons if you have other kids in your household and they're up to date on their immunizations, you get these coupons. And so we invested in this program like this. We got all of the hospital systems to have a program called the BAGE program. And we got all of the family practitioners, all of the OBGYNs to have the system with the coupons, and our midwives and nurse practitioners who delivered the babies. Everyone was a part of this system where they would give the fairly qualified community health centers, give the coupons to the pregnant mothers, and we spent over $500,000 a year buying free things. Our cribs valued at $100 from Target. You know, you have to go to figure out whether you're going to get it from Target or Costco's. But we were giving cribs worth over $100, new cribs, new car seats. They could come in and shop for baby clothing items or Pampers or you name it. But it's such a great program because they earned it, okay? If they took certain classes that we taught, they took a breastfeeding class and understood about the value related to that. They get so many coupons. So, and unfortunately for us, you know, because of this COVID pandemic, during our Christmas holidays, our supplies did not arrive at the time it should arrive. And so we had so many death threats related to our coordinator, honestly, because, you know, they felt that they made their commitment and the health department should have delivered. And I couldn't try to tell them, I mean, I can't get Target to get their supplies in on time, but these women will take it seriously if it's something that they have worked hard for. And now we are about to partner with one of our township trustees who want to provide free resources to all the pregnant women in their township, that they're going to start providing free resources for the pregnant women, whether it's car seats, whether it's cribs. And so we have a lot of philanthropic folks out there who will want to do things, and we just need to start thinking innovatively of different ways how they can partner with us. All the hospitals found a location, and they hired a part-time person employee or full-time employee to run that BAGE program. My job was to provide the funding for the resources and the materials at all these sites at $500,000 to $600,000 a year, but well worth it. And so businesses have a major role to play. Community health workers, whether they're OBGYN navigators, doulas, really critical because they're the ones who know where those food pantries are. They're the ones to know how to help someone if they haven't had a provider, how to get that appointment. They know where our domestic violence shelters are. They can help teach our pregnant mothers about postpartum depression. How do family members recognize that they've got a mother that's experiencing postpartum depression, and how do you get the resources to her? Child care assistance is huge for people trying to make their appointment, and we are definitely seeing an increase in our opioid dependence. So because of the COVID pandemic, our overdose increase has occurred significantly in our patients. So how do you manage those type of patients appropriately so that they're safe? And then telehealth, you're going to find more of us doing more of that. You know, all of our patients, most of them got a smartphone. So they love those applications giving them tips on the phone, especially adolescents. So look to see us do more and more of that. And my pet peeve, support living wages. It is $18 an hour, a living wage in Indiana. I think it's trying to go up to $19, but we're still at $7.25. And unless you're making living wages, we just initiated this month in our health department. We have 800 employees. 184 were making less than the living wage. So we've just implemented living wages for all of our employees or higher, that we think, hey, we need to be the example out there. I want to encourage all of you, if you're not doing it, to encourage you to do it. Our Ashkenazi Health, our public health hospital, they beat me to the punch. They implemented it 2 months ago, but hey, I'm a quick learner. I can learn. And so with that, I'll stop. Thank you.